Hello, everyone. How are we all doing?
Great.
Good. I am Jess Fargher, and today's episode of 5 Second Rule might just creep you out a bit, or maybe even bug you.
Dun-dun-dun.
I love it.
And I'm Kelly Holmes, and I'm happy to be here with both Jess and Stephanie. So when we think about infection prevention risks, or kind of the basics of infection prevention in healthcare, I think we often focus on hand hygiene, environmental cleaning, personal protective equipment. But what about that phone call when there's a bug in the hospital and those things that can literally creep, crawl, or fly under the radar? So in today's episode, we're excited to explore that often overlooked topic of hidden infection risks from pests and the important role of maintaining a safe healthcare environment. So from cockroaches to flies and other unwanted visitors, pests can contribute to environmental contamination, compromise patient safety, and create challenges for us as infection preventionists and our teams. So joining us today, we have Stephanie Stroever, who will help us better understand the connection between pest activity and infection risk, identify warning signs that healthcare facilities should be aware of, and discuss strategies that will help us in the prevention, monitoring, and collaboration across departments.
Okay, so before we dig in to what lurks beneath everything in the hospital, we're going to talk a little bit about Stephanie Stroever. But let me back up. It is Dr. Stephanie Stroever because she is wicked cool, an assistant professor in the Department of Medical Education and director of research for the Division of Emergency Medicine. She holds a PhD and MPH from UTHealth, School of Public Health, plus a BS in microbiology from UT Austin. Did you just have to keep going? You were just like, I want to be the smartest person in the room? Because not only that, but you teach applied statistics, epidemiology, evidence-based medicine, research methods from student level up through continuing medical education and faculty development. And as a research methodologist, you're guiding studies from the first idea all the way to published results. Your clinical specialty is in infection prevention and healthcare epidemiology. You're currently researching healthcare epidemiology, emergency medicine, medical education, implementation science, and maternal health. So that's way too much. I don't know how you're handling that. And you're equally at home in qualitative and quantitative research. And you stated that you enjoy both. So I'm sorry. We have an amazing person on our podcast today, and I was like, when I read over this, I was like, no, she's too cool for me. Way too cool.
Never.
We're so excited to have you, Stephanie, and I've had the pleasure of knowing Stephanie for at least a decade. I was trying to think about that the other day, Stephanie, about when we met and how long it's been, but it's really been a joy to know you throughout my career. So for everyone who's listening, you've worked in infection prevention and then went on to earn your PhD, and now you're an amazing contributor to the research in our field. So tell us about what sparked this interest in arthropods and their role in healthcare-associated infections.
Of course. And yes, I started as an IP, just like all of our listeners, and chose to go back to school for a PhD because it was important to me to further the field of science. I recognized that there were some really important gaps in the evidence base for practice, where we were sort of on the hook to make an evidence-based decision, a really thoughtful decision, and didn't have anything to support that. And that's what happened. Actually, I had experience where we had some drain flies, sewer flies, depending on where they're coming from is how you name them. And they look like these little insects that have little butterfly wings. So they're not fruit flies. They're a little bit bigger, and we had them throughout our sterile core. And we've moved to this approach to sterility, which is event-based sterility, which you all practice. And the challenge was, does this count? Is everything compromised since we have these flies throughout our entire sterile core? Or are we okay to keep operating? What do we do? And there really was no information in the literature. It was really hard to find. any kind of support.
So obviously you had to create it.
Exactly. Exactly. So the best that we had was just don't have bugs. And the truth is, well, that's not helpful when you actually have them. And so it really inspired me to say, well, I'm going to create the evidence then, because infection preventionists don't need to walk in. And this is tremendously disruptive to operations. You're making a difficult call. And I didn't like going in without supporting evidence. So to those hard conversations. So that's what inspired me to do it myself.
I'm blown away. So you were IP and you're like, I see a problem. I'm just going to continue going to school so I can create that research and bring it all the way back to IP. Do you have ADHD? Because I feel like that is what I would do. I'd be like, I'm going to spend the next 10 years to solve this one problem. It's fine. How long have you been working on this?
So the funny thing is, this was not on my radar until recently. I had a little stint after I had finished my doctorate, and we had moved back to Texas, where I worked as a director of infection prevention. So this was a little bit of a newer inspiration, but initially, I just wanted to understand why people don't do what they know they should do. We have infection prevention measures, and people just aren't doing it. And I didn't understand why. So that was sort of my initial inspiration to get my doctorate, was I want to be able to study why people don't do what they know they should do. And so then I'm doing research and a lot of different things, whether it's why don't trauma teams wear PPE when they're getting covered in blood, do we have good implementation of evidence-based guidelines for prevention of C-section infections? So it's all consistent with this gap filling that I want to do for the literature. And I probably just am too interested in too many things. I think everything's a great idea.
We could have you on for the rest of the year, just covering each topic that you are doing. That's incredible. Okay, so Kelly, do you have anything to add? Because my next question, I have a little clever pun. I guess I call it clever.
No, take it away. I'm excited for this pun.
Well, pests obviously don't belong in the hospital, but once you got into your research, what got under your skin? What has surprised you? I'm thinking of those scabies when I said what got under your skin. But anyways.
Yeah, so what I found really interesting, and again, sort of frustrating, was that there's a lot of literature coming out of your low and middle income countries, very little coming out of our upper income countries, our Western countries about this, and sort of exploring that. Again, the guidances just don't have it, just don't have bugs. And so I find that is really frustrating to me, but we do have them. Ask anybody. And we've kind of followed this study with a needs assessment that we're working on doing the analysis for. And what I'm hearing is that people do have pests. They do. We've got flies. We've got sewer flies. We've got house flies. We've got cockroaches. They are in our hospitals, and we're not writing about them. And so it's like this dirty little secret that don't talk about the fact that we have insects. But I think that we do have them, and we're probably not focusing enough on them because we just prefer that they go away and that we ignore them. And when I was working and we had the sewer fly infestation, I was the first person to raise the alarm. But there were people in that department. It was like 10 a.m. People have been there since 6 a.m. Why am I the first person raising the alarm? It's like we're kind of used to it, but also it's somebody else's problem. So those are some things that I'm finding just in my exploration of funding to do this work, in my exploration with a needs assessment and talking to other IPs sort of offline, is we just let it be somebody else's problem, but they're dirty and they carry really nasty stuff. And I don't think that we can let it be somebody else's problem.
Right. No, I love that you raised your hand and you're like, okay, this is a problem. And I find it concerning because you're like, no, people do know we have a problem. It's not like they are unaware of it. And then I'm just wondering, have you had to take psychology classes because you were like, I want to know why people are not doing this certain thing, but then also not writing about it? And do you think it's because if you write about your problem, then you're letting the world know you had this problem?
Exactly. And the hard part is if you publish in the literature, you have to put your affiliation. And so, oh, that hospital's dirty, and your C-suite does not want that. And I hate it because it's okay, but it's sort of one of those, it's okay if we acknowledge that we have problems because then we can fix them and we can help other people. But that's me thinking as an infection preventionist and a scientist and not as a chief experience officer who's like, OMG, if you talk about the bugs here, like I'm going to have a cow because it's totally opposite. And so finding a way to collaborate with those individuals to do the research, I find myself a little bit stymied and then that I have to get creative. And then in terms of taking psychology, actually my major for my PhD was health promotion and behavioral sciences because yes, there is a huge psychological component to health behavior or behavior in general. And my background was microbiology and epidemiology. And so I really didn't know how to start. And so I leaned into that for my doctorate and still minored in epidemiology and quantitative methods so I could do all the things. But I really wanted to lean into that training, that side of training that I didn't have.
Oh, I love that. I think you presented your research on the flies that you found in your sterile core. Was it 2 years ago or 3 years ago at APIC? I was part of that session and it was very good because you did some hands-on, what would you do in this situation? And we had to get uncomfortable and talk to our neighbors about how we might solve this problem. And then went about doing this systematic review, which is really going out there, finding every single paper that's about arthropods in a healthcare environment, a huge amount of work so that you could provide guidance for infection prevention so that we can kind of know what is out there, what has been talked about and written about. And I also thought it was very interesting that most of the studies that talked about this were outside of North America. Yeah, so that was, I remember just thinking that was very surprising. And all your reasons for why people don't publish in North America about this problem it's sad but true. So I think the systematic review can really provide a framework and be helpful for infection preventionists moving forward when we do get this question posed to us. So knowing all this, how concerned should we be as an IP when we encounter these pests in our patient care spaces? Do we freak out? Is it DEFCON 5? Tell us about it.
Yeah, I think that's where we run into the limitations of the literature. So what we found was they are in healthcare facilities and they are leaving their gooey fingers everywhere. And they have gooey fingers that have multi-drug resistant organisms on them and they're yucky. And there have been a couple of papers who they didn't have a direct causal link, but they made a really great case for the fact that these insects are in some way tied to this outbreak. And by controlling the pest, we also controlled the outbreak. And so I think, one, yes, we should be concerned. And we should be asking the question of how prevalent are they? Are they all over everything? And what we don't know yet, and this is where I'm headed and that I'd like to be headed if I can really encourage funders to be interested in this as well, is making that connection. If we have cockroaches running around on our sterile core supplies or even in our clean linen rooms, in our clean supply rooms, do we need to be concerned about maybe maybe we won't even see them, right? We see they're dead now, but we know they were in there or we saw them in there. And now can we take that clean supply into a patient room without it being a risk to the patient? That's what we don't know. I'm less concerned about, especially in North America, cockroaches crawling on people. I'm less concerned about. That's probably not going to happen. I am concerned about their movement at night in our clean supply rooms, crawling on things, leaving their goop as they go, and then us not knowing. And we don't know. We don't know if it's connected. We don't know. We know that there's nasty biofilm in our drains. And so sewer and drain flies coming up and sort of hopping around on our supplies in our patient rooms or anywhere that you have a hand washing sink we have hand washing sinks. We put up those barriers, splash guards. But if you have drain flies hopping around in your clean linen rooms, or not linen, your clean supply rooms, the splash guard's not helping anything. I mean, it's helping the splash, but they're pulling up bacteria, multi-drug resistant bacteria that they've been living in these drains and distributing them. And that's what we don't know. We don't know if there's that indirect transmission. And I think that's a gap. And I think you could make the case that look what they have, and they've been over here. I feel like we should be concerned, but can I say definitive to a CEO or a chief operating officer who's like, do we really have to shut down the OR because of this? I don't know. And that's really frustrating. And I wish I had that information. I like to think no. Right? What we did was we recognized that there's an outer wrap and an inner wrap. And so the outer wrap didn't come anywhere close to the sterile field. And we checked to make sure they hadn't climbed under those outer wraps. And we reprocessed everything that was in the bulk of the volume. It wasn't enough for me because I was like, they could be everywhere. But it had to be good enough because we still had surgery to do. And so we had to sort of trust that we mitigated the issue as much as possible. And one of the hardest things I think is people say, well, we've never had an issue before, but if we haven't looked for it, then how can we say we haven't had an issue? It's like, if you don't have your eyes on it, then you don't know what you don't know. So that was a long answer to say, I don't know how much we should be freaking out. I think if I'm seeing insects in my clean rooms, I would be concerned. I think if I'm seeing drain flies in anywhere with a high risk population, like your oncology wards, your ICUs, there's greater concern just because they're more vulnerable to any sort of indirect transmission. They can just pick things up more. And so that's where I would be more concerned than perhaps some of your lower acuity patient care areas.
I'm going to speak on behalf of all of the listeners right now, and I have the chills. As you were talking about all the different ways and everything, getting just the goosebumps, thinking about, oh, yeah, not just bugs like what we refer to as our infections, but real bugs just crawling over everything at nighttime. Thank you for that imagery. I really appreciate it. I am really happy you shined a light on that, but that is disgusting me. So thank you.
Yeah. And thinking about, I always try to take the stairs when I'm doing rounds, and the cockroaches that you might see, I mean, at least they're dead in the stairwell. But then also if you have a large homeless population that your hospital might serve, we've definitely gotten calls where there's maggots in the wounds when the patients come in, or for terrible news if someone's like, oh no, this person didn't have any bugs when they came in, but now there's some flies under their dressing, or it's clear. It doesn't happen very often, but in my 20 plus years, it has happened. And you're like, where do I go? What do I do? What is the correct step forward here? So I think it is important work.
Mm-hmm. It actually makes me think of, here's another idea for a project for you, just home health. IP, and I just feel terrible. And I recently was down at my grandma's, who lives in a town of 300 on a farm, secluded. There's mice on this farm and everything, and does dialysis at home. And I walked in that house and I was like, how are you keeping this a sterile environment? It just floor, and I see the little dead bugs everywhere, and I'm like, okay, all right. Anyways, just a little tangent I had to throw out there. So if you want to research home health, infection prevention with arthropods, there's another avenue.
I'm all over. And what we do see that was really wonderful to come out of the systematic review is we get a great visualization of what pathogens they do carry. Yes, they carry a lot of common commensals and environmental organisms that maybe we're not worried about in your average healthy person. They do carry a lot of multi-drug resistant bugs. I'm not even going to say bacteria, because there's also aspergillus and candida. And so they are carrying that as well, and other types of fungus. So we do get although we've kind of, unfortunately, the literature has sort of stopped short of making that causal link, I do think that we have a great body of evidence of what they do carry, and that it isn't good. And that we should perhaps be saying, okay, how are these multi-drug resistant bacteria getting from place to place. And maybe it's not just hand hygiene. It could be, I mean, it probably is, but it might not just be hand hygiene.
So when should we consider pest if there's like an outbreak? When is the, oh man, that's the moment that I had this epiphany and it could be pest?
Yeah, I think I would include it as part of my overall assessment. If you have an outbreak and you're going in to a unit to say what's going on, I think that's when I would start asking questions about it. I know that burn units are really sensitive to biofilms in their sink, that there have been outbreaks associated with splash and the biofilms in sinks. Other units similar. I have one of my colleagues on this paper. She works a lot with biofilms and has done research in burn units. And that's just one, right? Like we could blame the sink and the splash, but maybe we need to say, hey, has anybody seen any drain flies? Has anybody seen any fruit flies? Fruit flies are really those that are going to be like in your kitchens, right? But so if you're seeing flies in drains, and I have a colleague who's an entomologist, so I'm learning new things. So if I miss speaking at all about this, I apologize. I'm definitely not an entomologist. But my understanding, if you're seeing them not sort of close to a food source, but over by other water sources, those are more likely to be these drain flies, sewer flies, filth flies, and not fruit flies. So they're not harmless. And so ask your staff, hey, are you seeing any kind of insect? And nothing is harmless. Like any kind of insect activity is important for us to know about. In addition to how's hand hygiene going? Are we cleaning our carts? Are we cleaning our shared equipment? Make it part of your conversation.
Oh, I love that. Yeah, because we do all get that dreaded call. And I think that maybe one of the reasons that people don't talk about it very much is because we don't know what to do. You might call facilities and say, hey, can you call in our pest people and have them spray? And then the conversation stops there. They're like, sure, they'll come in and spray, and maybe the problem goes away. Maybe it doesn't go away. So for IPs, thinking about assessing this risk, how would you advise them to make decisions about supplies, or just really what is the next step beyond calling facilities and be like, hey, can you call the pest service?
Yes. So speaking with my entomology colleague, he's at the Texas Tech Veterinary School, Dr. Chad Cross. Speaking with him, it's important that IPs recognize that it's not enough to just spray passively on like a schedule. Like spraying is good in theory, but there really should be active surveillance. And so it was part of the reason why we're doing a needs assessment right now through the APIC Research Network. And we asked our participants if it was allowable for them to share their integrated pest management plan for their facility, because we wanted to see what else included. Do we have our IPs and facilities actually generating robust integrated pest management plans, or are they sort of like light? And unfortunately, we got only 3 out of 40 that were integrated pest management plans. The rest we got were like bed bug management plans and things, which are different. And so infection preventionists first need to recognize there's an integrated pest management plan that your facilities and your EBS and you should be included in the conversation, because they do carry microbes. And so it's not just an aesthetic issue, it is actually a environmental contamination issue. So there is a difference. And it should involve more than just routine spraying. There really should be there's some great resources from like the EPA. If you just type integrated pest management plan and infection prevention, I can share this with y'all as well. There are a couple of really great guides on what should be included in an integrated pest management plan, but active surveillance for those, and like having a monitoring log. So you want to train your staff to, hey, pick up the phone if you see a cockroach in the stairwell. Even if it's dead, it came from somewhere and it's been walking on something. And in glancing at the data, we're still doing the analysis from the needs assessment. But I asked, okay, when you see insects, are they dead or alive? And most of them are alive. And I'm like, so it's not just the dead cockroach in the stairwell. These are alive. They're alive. And I know. And so they're traveling distance, especially cockroaches. And so train your staff. Like, this isn't just a call to EVS to spray. Let's document it. Let's make sure infection prevention is checking in on this. Maybe even include it in your infection control committee meeting. Like, how are we doing in terms of pests? Just maybe quarterly, like you do with your water management plan. Let that in your construction, right? Like, we tend to be pretty involved in those. Let this be one of those things too. Attend those meetings and really make sure that you're aware. And I would say, if you do have an outbreak, Dr. Jennifer Hanrahan, years ago, they had a multi-drug resistant, I think it was a carbapenem resistant, I don't want to say the wrong thing. They had an Enterobacter cloacae resistant outbreak. And they found that they closed the rooms from these. They did extensive terminal cleaning, and they closed the rooms. And then they were doing environmental sampling, and they found it again. They're like, but the rooms have been closed. So how did it get back in here? And so the hypothesis was cockroaches. And so they did snag some of the cockroaches that they were finding. And again, it's not causal, because you can't say that cockroach caused that patient's infection, but it was a similar bug. As far as the genomics were available back then, it was similar. It was similar enough to be suspicious that it could have been contributing in some way to this outbreak, and enhanced activity for infection, for pest prevention. They ended up mitigating or ending the outbreak. So again, not a direct causal link, but a good enough reason to think that maybe it was involved. Sorry, and let me get to the point on that. My point was, maybe start grabbing those insects, hold on to them, have them contribute to, if you're doing any kind of genomic tracing where you're looking to see if there are things that are similar, maybe send that guy. Also, walk it out on plates, or see if it's got the same bugs that your patient has, the micro kind, not the macro kind in this case. And see if they have similar bacteria or whatever. See if it's got that pathogen that you're concerned about. Do some genomic testing. And if that's the case, really an extra emphasis on prevention. Same thing for infection preventionists. Note the age of your building. Older buildings are just going to be more common these days, right? Because we had these, for every one new state-of-the-art facility, we're going to have probably 10 aging ones, right? Or more. And so it takes more upkeep to keep the insects out in aging buildings. And so really maybe even have a conversation with you, your EVS, your facilities, whoever's in charge of that, with your pest management company, to do a critical risk assessment, like what's going on around our building that can make it more susceptible to infiltration.
Okay, you're blowing my mind. But for the people like me who would not know where to start. So you would say you need to team up with EVS and facilities, and it sounds like laboratory, because you might want to do testing. Would that be, and I'm not saying you have to have the overall answer, several policies, one policy joined? Who would own that policy? Because I feel like there are so many times where maybe infection prevention is given a policy and you're like, this really has nothing to do with IP, but it is IP. And also, how do you implement like lab? Like, who does that fall onto regarding, again, you do not have to have the most perfect answer, but for our listeners who are wondering, how do they start that? How do they set it up? Can you help us out with that?
Yeah. So Joint Commission and other accrediting, you have to have an integrated pest management plan. So that's where I would start. Use those terms and ask your facilities or EVS. If you've never even heard of this before at your facility, then it probably is owned by facilities or EVS. And so what I would say, or your chief operating officer, right, it's going to fall under their purview. And I would start there, because you have to have one. And so maybe you're just not aware that it's there. And then what I would do is I would just start asking questions like, what are we doing? And think like an infection preventionist, right? Like, we do surveillance on micro, we do surveillance on our environment of care. Ask questions about surveillance. Like, how are we doing how are we tracking that this might or might not be a problem? Are we actually writing it down when we call our pest management? Are we following up after we call them? I found actually that we sort of outsourced this to our pest management. And when we were circling around a week later, I said, okay, well, what did they do? And nobody could really tell me. And that was like, okay, we have to know what they did, because what I don't want is to continue seeing these drain flies in our sterile core, because it's just going to perpetuate the issue. I need to know that you actually, so that follow up. So I would start the conversation with the people who likely own it. If you're not aware of it already, I would ask the questions on what kind of surveillance are we actually doing? Are we tracking this? Are we looking for sort of those peaks? Or when it starts, you've got some level of normal and then all of a sudden you don't. I would do some education of your staff, your healthcare staff, to say, hey, if you see them, and especially in your high acuity areas, your procedure areas, really emphasize, like, this is not something we want to ignore. It's not somebody else's problem. And if you can't reach somebody, call infection prevention, right? Not that I want you to have to do one more thing, but I think it would be better if you at least knew, so that you could be the squeaky wheel than nobody being a squeaky wheel and it kind of being perpetuated. And then the last thing I would say is, I don't necessarily think infection prevention needs to own it. I do think it's an environment of care or facilities type policy, but you should have, just like your water management plan, you should still have a role in what's going on, and you should still review maybe quarterly the data that's coming from there and ask those sort of critical questions. I think one thing I was sort of complacent before that, and even like following that, because you just have too many other things going on. Like, maybe you can have one of your IPs who does environment of care, or your IPs responsible for your procedure area or something. Be that person who's or your ICRA IP, the person who's monitoring construction, who kind of owns that. That way they're just kind of, it's still on your radar.
I can hear like one of the listeners being like, I'm the only IP. Yeah. And I just have to tell you, you got this. Be brave. Exactly. It might seem like it's Pandora's box, opening it up and like coming out to new problems, but these are problems that have already been scattering around all around. So we're just shining a light on it. But you got this, IPs. I know you do.
Yeah. And I don't think EPs need to take it on as their job. I think they just need to have it present. So put it on your infection control committee agenda. Have those individuals report on it and ask the critical questions, and then let those who are responsible for it manage it. Just don't ignore it. And then definitely keep it as a question mark in terms of outbreaks or weird organisms. If you're seeing environmental organisms or things that you're like, this is unusual, maybe it's coming from the outside via grubby fingers on cockroaches.
So, Stephanie, what was your solution when you had those flies in your sterile core? Yeah. Or a lot of times we'll see the fruit flies in the kitchen and everybody's like, we've tried everything. We don't know what to do. Like, what was, if you don't mind sharing, or if you do have, this is what we did and this seemed to be what worked, what was that?
So, actually, it was a very long process. I think that's probably not what anybody wants to hear. I've had some colleagues around the country who have had some issues. One who had drain flies in their dialysis suite, another in their sterile core and OR. And it does tend to be a long problem. So don't let anybody say, oh, just spraying is going to fix it. So what we did for the initial issue was we identified where the heaviest volume of these drain flies were at time of discovery, and we reprocessed all of those things on that side of the sterile core. Then we had to make a decision about all the other things, because I'm like, it's still possible that they were on here. And so we agreed that we wouldn't reprocess those, but rather we would be cautious with the outer wrap in the OR, keeping it separate from the actual procedure table, checking it, just sort of opening it away from the field when we were opening to make sure nothing had climbed under or crawled under the outer wrap. Just discarded that and then moved the set in the inner wrap onto the table. So we sort of took extra caution with that, and like changing gloves and all of those things. In terms of the actual elimination of the drain flies. Oh, and we also did terminal clean. So a terminal clean as much as possible. We had some of them sort of, our sterile core had doors to the OR. And so some of them had climbed under the door. And so we did find that there were a couple of ORs that had them too. So we closed those and terminal cleaned them before opening them back up. And then we monitored, and we did have several more instances of the drain flies in the sterile core. We were able to figure out where the heaviest burden was, and we walled it off. So we used like construction techniques where we walled them off. And so that we didn't have to worry about them moving into other parts of the sterile core. And then we had to really figure out where the source was. Initially, we thought it was that there had been some old autoclaves in there that hadn't been properly capped. That didn't end up being the case. Actually, we had been doing some construction several ORs over, and there was construction in the ceiling. And it ended up that we had some moisture that was dripping, like kind of flowing on the outside of the pipes, landing still in the ceiling. So it was above ceiling, puddling, and we had the drain flies there. And so they kept falling out of the ceiling. And that's where they were coming from. And the hard part was getting I hate to say this because we have so many good facilities folks, but they didn't want to listen to other ideas. They were convinced it was the autoclave. So no, it's fine. It didn't end up being fine. And so they had to get creative and keep looking. It was like, it took us 3 or 4 weeks to really find the source. And so get creative. Don't assume that you know where they're coming from, because it could be the construction several ORs over, or even in a different part of the building, has sort of opened up this opportunity of entry for these things. And so you just have to be creative and not think you've already found the solution. And then again, contain and keep investigating.
Aha, very good advice.
Yeah.
And yeah, I think you've covered my last question as well before we go into the lightning round. But if there's anything that you could change about how healthcare facilities and IPs kind of approach this topic, what would it be?
I think just not considering it just like an eyesore or an aesthetic issue, but rather that they do carry nasty microbes, and it's worth the conversation, not just sort of sweeping it under the rug. And I think, I wish we could do puns all day. Don't just sweep it under the rug, just sort of like dust, right? We don't want to ignore dust. We don't want to ignore pests. We want to address them and not make it somebody else's problem. And do follow up. And then if you have them, talk to each other about it. It's embarrassing, right? It's like our dirty laundry. We have a lot of facilities that are now part of networks. We have our APIC chapters. Like, talk to each other about it. Make it less of a taboo topic. And that way you're sharing knowledge. I did find from that session at APIC, you had people in 2 camps. You had the freak out and reprocess everything group, which was where I was at the time. And you had the, oh, it's no big deal, they're just nuisances group who did nothing. And I was, okay, so if I'm a young IP or a new IP and I'm just getting started in this field, I'm getting very different suggestions depending on who I talk to. And so we do need some consistency. And I think the best way to do that is to start talking about it and have some consensus. And I do think like the CDC and others, they need to update the guidance that there aren't just nuisances. As far as we know, they carry nasty stuff. And so let's see if we can move the guidance further away from just don't have them to here's what you do if you do. I think that's another thing that the field of infection prevention can do is make some really actionable steps for IPs who find themselves in this position.
So you need to pester people.
Yep, you do.
The puns
Also,
just keep coming.
I mean, I have to. It's me. But like future, like I'm seeing in the future, maybe any CDC person listening to this, you should check out Dr. Stephanie's research and possibly implement that into your guidelines or give her a call. And speaking of that, if anybody wants to reach out and maybe ask you a question, do you have a LinkedIn? Do you have a professional email? Are you on other podcasts? Maybe are you in some other type of like upcoming podcast? What's going on?
Yes, so all of those things. So you can certainly email me at my Texas Tech email. So stephanie.stroever@ttuhsc.edu. If you just type in Stroever and TTUHSC, you'll find me on like our faculty page. I also have LinkedIn, so you can search for me there and connect that way. And then I'm also going to be on the AGIC podcast in a couple of weeks related to a different project. But again, I just love everything. And so I'm really excited to be talking about something different, but still infection prevention related. So, and I would love to have these conversations. It's my goal to actually answer the question, do we need to be worried about indirect transmission? If you just type infestation and Stroever in like Google Scholar, it should pull up, and save it and use it to help you as you are justifying the energy that you're putting into this. And I think that's another thing that you can do. Like, my goal was that future IPs will not struggle the way that I did with difficult calls with no evidence.
I love that. I absolutely love that. You've been a hot dog of a guest. I don't have a bug pun for that one, but our lightning round lots of people have told me have been really fun to listen to, and I'm going to add something that's not on there. I need to know, not regarding the podcast, but the podcast name. 5-second rule. Yes or no?
Yes.
Yeah, even though with all of the things you just told us.
I mean, it needs to have a little rub off or blow. It depends on what it is. Let's be honest. If it's something that's wet and could absorb more, like, absolutely not. It's going in the trash. But if it's like an M&M and you could just like kind of brush it off, I'm totally eating it.
Hard candy coating.
Especially if it's my only one.
This next one, actually, so Kelly put this in, or someone did, but it like hits home for me because I have a fear. But ants or cockroaches?
I prefer ants. I lived in Dallas for a while, and we had tree cockroaches, and they found their way into my home. And so they would surprise me. This is when we had babies. I'd go, it's 4 a.m, 5 a.m. I'm about to make coffee, and I open the cabinet and there's a roach right there looking at me. And I just cannot. I hate them. They also fly, and like some of them do. And I just, so ants. I'll take ants all day long.
Agree with that one. Living in our house, we had tree roaches. That's what my mom always called them, because they were giant. But I definitely had one on my toothbrush at one point in time. And I was like, well, I just went ahead and brushed my teeth. Still here.
Yeah, I think in that case, 5-second rule. Yeah, that toothbrush is in the trash.
So you had said ants, and I have a terrible fear of them because of fire ants in South Carolina crawling up my body. I had like hundreds of them. It was terrifying. Okie dokie. Next one. Favorite vacation spot?
I was thinking about this in advance, and I think this is going to sound so hokey, but my favorite vacation spot is anywhere that my family is. I tell you, my kids are they're 15 and 13, but I feel like their feet are out the door already. And so I just want to be with them. And so we did a couple of vacations this summer, one where it was just my husband and I, which I still really enjoyed, but I missed them. And then we went on another, and I just love being with them. So our 20th wedding anniversary is coming up next year, and we wanted to take a big trip, and I couldn't decide where to go, but it's because we were leaving them behind. And now I'm like, can we just take them? Now I'll decide all the things. So we're going to take them. And now I'm like, I'll go anywhere. Everywhere sounds great.
Next year, APIC conference.
Yes, I hope to be there. And so, yeah, anywhere that my family is right now, that's my favorite vacation spot.
Okay, well, that makes my soul
it's
so
happy.
That resonates. Absolutely. Mm-hmm. Yeah. My oldest is going to be a junior in college, and that was just so hard when he went to college, and the realization that how fast it all goes by. So yes, I agree. Hold on to him. Soak up all that time. So what is one piece of advice, Stephanie, that you would give your younger self?
So the advice I try to give my younger self is to chill out. I can be pretty high strung. But at the same time, I would also tell myself that you were made that way. And so don't let anybody tell you have to have a thicker skin, or that you aren't effective the way that you are, because I actually think I'm sensitive And I'm also high strung, which makes it really hard to be an infection preventionist sometimes. And I would just tell myself, my younger self, that it's okay because that's how you were made, and just to lean into it and see if you can manage things to still be effective even in that space, but then be kind to myself. I was really hard. Yes, I do need a thicker skin. I hate that I'm so sensitive. I hate that I'm so high strung. I just need to chill out. So I was really hard on myself. I think that there's a reason that high strung sensitive people exist in the world. And so that's what I would tell myself is figure out how to manage around it, but don't try to change yourself.
I know we're running out of time, but do you have anything that you're reading, watching, or listening that you want to share with us?
I have been watching the CrossFit Games, and I really enjoy just having something on that's sporty in the background. And then I had finished watching the World Cup, which was really fun. In terms of listening, I do really enjoy listening. So I drive to and from Lubbock some, and I really enjoy listening to audiobooks. And so historical romance that's not dumb. Like, I don't like tropes.
You're
so I'm
still
constantly
learning something.
looking for non-tropey romance novels. So Amy Harmon is my favorite author. I'm just going to throw her out there because she writes fantastic historical romance that is more historical than romance and just tells a wonderful story. So anything Amy Harmon, I can't wait till she puts out a new book.
Very cool.
Yeah, I'm going to write that one down.
Yeah.
Thank you for being such a beautiful guest today.
Oh, Stephanie, it's always such a pleasure to hear what you're working on. You are contributing in a major way to our profession. So thank you for going down and blazing this trail of what to do when we have pests in our healthcare environment. And we look forward to the research that is coming next. So thank you very much for joining us today.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.